Although you can't see it, we are now recording. So, first thing, before I get today's just going to be review. Again, I was trying to get the review accessed and sending the review to everybody. I said we are having a little difficulty with these YouTubes being consistently available, and my colleague Dr. Buxton and I were talking about that this morning. So we will figure out a way to make sure that you get it. So I had a number of emails over the break, which is great. I like staying in touch. And a lot there, inevitably, right before break and right after the break, there's a lot of congestion of exams. So I felt it was the best course of action to offer the exam on two different days, your choice. So you could, if you want to take it Wednesday, where I originally was planning, or Friday, either one's fine. You don't have to come the other day. So it's your option. Come in Friday, don't come in Wednesday. Come in Wednesday and get the exam over with, don't come in Friday. I will have to provide, because of between this review and the exams, I'll have to do some recorded lectures. I will do that today and tomorrow. It's just me, the dog, and two cats at home for the time being. And unless the dog's barking, it's not a problem. It is. So I will send you some recorded information because the material we're doing now about like epidemiology and how diseases spread and the damage they do is fairly straightforward stuff in the sense that I'm more or less sitting there reading PowerPoints to you, which isn't a lot of fun. And 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 the meat of the next exam is mostly the antibiotic, antivirals, antifungals chapter, which will undoubtedly will probably start by Monday. That's that's the back information. I'm perfectly available for questions, email, and things like that. It's hard. I mean, if you can't confer with me here, I mean, I'm happy to do a video link with you. It's not a problem. I already have one student scheduled for that. If you have questions like that, these days, it doesn't matter. I forgot my computer. It's in the office. Thanks for reminding me. It's for my lab downstairs. That's where all that stuff is. All good. Can I begin? You ready to review? Does anybody have any specific questions? You want to wait till I'm done? If you have it. Yes, no, maybe so. A little more interaction. Well, look, I didn't drink as much as you must have, doing right? Despite my son introducing us to the wonders of a recipe called a Singapore sling, developed in some bar in Singapore, which involves like five different types of liquors, gin, and a whole bunch of like cordials. I was near comatose. So I don't drink at all. On the golf course, I mean, he and his buddy had 3 beers before we started. What do you want a beer, Dad? No, I'll have a Diet Coke. Oh, okay. Oh. Moving on. So this is the way I usually do reviews. So you can all listen to this. I'll somehow get a copy to you in some way, shape, or form. So I just look at the darn uh, thing and start. The, First of all, the genetics part is about 15 genetics questions. There's about 20 physical and chemical methods of control questions, and about 25 to 30 ballpark of questions about viruses. So, in your studying, if you wish to pay a little less attention to genetics, I'll try to give you exactly what's on there. And I make your focal point virus and uh, the chemical and physical methods of control chapters. We start. I'm just looking at the test. It starts with the chemical methods. They are not by trade name; they are by category. So aldehydes are formaldehyde and glutaraldehyde. Alcohol is its own category. Biguanides are this very, very popular one that you see marketed under Hexacleanse or Hibiclens, ubiquitous in hospitals now. The best of the antiseptics, very user friendly. These are the categories. I'll give you some comments on them shortly. Peroxygens, basically, that's the most common thing that we use in the form of hydrogen peroxide. There's other ones, but peroxygens, I won't ask you, the answer isn't hydrogen peroxide, it's the category. The way they're phrased, the chemical class or the category, peroxygens. Poison gas is ethylene oxide, it's a category unto itself. Clorox and Clorox related things, as well as betadine and iodine, are in the category of halogens because that's their chemical class based on the periodic table of elements up there, imaginarily or otherwise. So that's how you have to know the quats or quaternary ammonium salts. There's a whole lot of different names, benzalkonium chloride. But if you're using pump antibacterial soap, that's what you're using. If you're using a Clorox wipe or a Lysol wipe, that's the active ingredient. That's an antiseptic. So, I mean, that's how I feel that you need to know them. And that's the way they're. So, all of these first battery of maybe 8 or 10 questions, they basically involve those categories in some way, A, B, C, D, or E, and I give you a statement about them, and it's like at the end, you know, this agent is a blank. We use it all the time. Blank. It smells bad. Whatever. Enough that you could identify it. You pick out the category. Okay. So let me do it one by one. I want to avoid, to a certain extent, all the controversy over the last test. I also want to avoid making the test, basically telling you everything is on the test, just telling it to you and having you regurgitate, because part of it is your test taking skills are very important to develop. If I'm relatively forgiving, I mean, I'd be surprised if most people didn't get the grade they need to get in this class. I'd be real, you will not get the same courtesy, believe me, out of instructors in other divisions. I don't want to say nursing. See, I didn't say it. Burn the tape. Okay, moving on. So, when you cold sterilize, the implication is liquid. Okay, the problem with liquids, time. Clorox on a desktop is not sterilizing, it's disinfecting. You're just removing a certain amount of microorganisms. That's disinfection on an inanimate object. It would take 6 to 10, maybe 12 hours, as little as 3, as much as 12 hours, to have Clorox lay it on this. The poor desk would die. Okay, that's why we don't use it. But when we do use it for instruments, as I did for my practice for a quarter of a century, we put it in like a glass tray and let them soak overnight. The agents are typically aldehydes, most popularly glutaraldehyde. Formaldehyde, we used to use that in immunizations, and that was a problem because the stuff's nasty. It's a nasty toxin we're injecting into babies. Okay. So, but that's that category for that. When we talk about surgical scrubbing, we use 2 agents that are similar but different categories who are enhanced by the presence of soap. They work better. One are the biguanides. Typically, that Hexacleanse or Hibicleanse, however it's marketed, and it'll be pumps of it in the hospital, comes out as like a red kind of liquid or gel. When you mix that with soap and foam it up, the foam is like between a white to pink color, very distinctive. It's great. Not only is it great as an antiseptic for your hands and very effective in hand care, it is particularly effective on catheters and other indwelling things, much more so than what we used to have. So it's very compatible with skin and linings. That's why, and the biggest problem we had with infection in the hospitals by far, and has reduced because of these methods to some extent, were urinary tract infections from long-term indwelling catheters like Foley catheters, which, take it from somebody who's been in that road, they are not fun. I have had bladder and prostate surgery on more than one occasion. Okay, so that's the biguanides, and another name, and the typical name you see is chlorhexidine. That's associated with it. If you're using a gaseous agent, for sure it's ethylene oxide. Anything that's incompatible with chemicals, liquids, heat, we gas clave. Effectively, we take a room this side, stack it, and if you're opening up sterile Q-tips, needles, syringes, those have all been gloves, masks, not necessarily masks, be the wrong one, gowns, drapes, all of those have been gas claved. They have placarded in something that's sterile, compatible, seal it, put it in a room with the gas, expose it to the gas for X amount of time, pump out the gas, somehow make it fit to dispose. So effectively, they create a room that's a gas chamber. It's extraordinarily useful, and the agent. I don't even know if there's another agent other than ethylene oxide, so you should be familiar with it. When it comes to the halogens, there are really two that are of any relevance to us. One are the chlorine-based products, and that's why we use Clorox or similar agents. It is much too strong when it comes out of what you're going to go buy to Walmart to maybe add to your laundry or use for some household use. When we use it as a disinfectant, we dilute it roughly an ounce to 100. So it's about like an ounce in roughly a gallon, maybe an ounce and a half in a gallon of water. It's 128 ounces in a gallon. And that's perfectly effective as a disinfectant. And it's very broad based. It's as useful as the big problem is the vapors are rather unpleasant. If it gets on your skin, it's not nice. That's why it's a disinfectant. A lot of these overlap. Clorox, I don't think is one. That's never going to be an answer. It's never going to be friendly to the skin. Iodine and betadine, and the whole idea was that iodine in the old days was released so rapidly it stung if you had an open wound or a cut. So they took iodine and they attached it to a protein carrier called povidone, and when they mixed them together, the iodine was released much more slowly and much more compatible. We could use full strength as a solution to prep skin for surgery or to put on wounds, not open wounds, but even initially, if someone came in with a cut, we'd soak them in that because it was really could be. It's not good for long-term wound healing because it's somewhat toxic to new cells that are growing. So that's something else we dilute. But betadine is great with soap. The difference between that and the chlorhexidine is the soap has like a brownish color. And if anything, chlorhexidine is a touch more effective for scrubbing for surgery. That's where you end up going with your career. So most of us prefer, I think it's a little kinder to your skin. We only really had betadine when I was there as a choice. The other was just really getting started. And I mean, my skin would break out from, we'd scrub, 8, 10, 12 times a day when we were on a surgical rotation, that kind of stuff. So it really was a little bit irritating. I always had a tan from the betadine tan. So that's the difference between those that are there. So typically, when we use it for long-term care wounds, we'll dilute that. We do the same thing with peroxide. By the way, they're a little too strong, full strength. And other than an acute one, like I just cut myself, different story. Okay. Metals are significant for two major reasons. Historically, when we used iodine, we used something else called merthiolate, a mercuric compound. Mercury is a metal, even though it's liquid at room temperature. And it was red, and we used to put it on little cuts and scrapes like that. Little kids, your grandparents' age, ask them about tincture merthiolate. In the old days, when we had cavities, they made fillings out of silver and gold amalgams because those were very effective. Babies had silver nitrate, something you all used in chemistry in high school, in their eyes because of gonorrhea and other sexually transmitted disease during vaginal birth. Nowadays, we use topical antibiotics because the silver nitrate left blackened the skin, even just transiently. But the moms and dads go, "Oh my God, the kid's got black eyes already." So we don't use it. But the big player with regard to these is the use of mercuric compounds in vaccines. For years, the two agents we used were formaldehyde, a nasty toxin, and something called thimerosal, which is a mercuric compound. You and I would ingest more. If we went to a fish fry Friday night for Lent, which I can't do because I'm on keto. It's killing me. French fries, coleslaw, fish, tartar sauce. Uh, hurts. Even the Jewish kid going to, St. Everybody's Church. Okay? Sorry. I'm non-denominational here. You'd get more mercury. There's mercury in fish. But if babies have a new nerve system that hasn't developed. So the research was faulty, but it started the wave of the concern for the uptick of autism with thimerosal containing vaccines. Everybody jumped on it until, and even they disproved the research. The reality is no one has ever proved a link, but no one has ever disproved a link. Short answer is we don't know. So my recommendation for vaccines is get them thimerosal free. You can. If your physician says no, go to somebody else. There's a lot of doctors out there. It's not like the doctor is God anymore. There's more doctors than there are patients to a certain extent. So doctors have to be user friendly. So down the road, if you're going to have a family, all those are your decisions. That's my 2 cents. Same advice I give to my daughter. Same advice I gave to my son, the 2 who have kids. My other son does not have children. So I would ask you to remember that, and I always mention it when I do this unit. Again, when we talk about toxic levels of gas, it's oxygen. That's peroxide. You have open wounds. You have cells. Cells are damaged. They release catalase that's in them. All of our cells have them, and it converts peroxide to oxygen gas very rapidly. That's why it stings, but also most bacteria that causes problems are incompatible with large amounts of oxygen. So oxygenating wounds, exposing wounds to sunlight, have been around for a long time, long before we had pharmacology that limited that. So those are the basic areas that I would have for all the, what we call the germicidal agents in their categories. Physical methods: heat, moisture, dry, radiation, mechanical action, like I feel is most important part about hand care, irregardless of the agent they're using. You could use no water or plain water, but the mechanical action plays a role. So all of those are physical method. Filtration is a physical method. We're using some non-chemical means to accomplish our goal. From a definitional standpoint, the definition of sterilization is because we don't know enough about prions to incorporate. The hardest thing that we know of for sure are bacterial endospores. So if you sterilize something, you use some method to remove all microorganisms, including and up to bacterial endospores. If you got the endospores, you got them all as far as we're concerned for now. That's sterilization. There's a lot of ways to do that. Again, when we're using the germicidal agents, if we're using them on living tissue, they're called antiseptics by definition. Only antisepsis is what we use to remove microbial entities on living tissue. On inanimate objects, it's disinfectants, period. Yes, there's overlap, but not a ton. Most are better at one than the other. I remember these numbers. We use moist heat, pressurized steam, because it penetrates and the particles are so tiny they get everywhere. There's no way 2 objects could be on top of each other and steam can't get through, unlike dry heat, because basically it's high velocity water molecules that are doing the job. The numbers are, for an autoclave or steam sterilizer, 121 degrees Celsius, 15 pounds per square inch, and I'm using 15 minutes. Okay, I'm not using 20, so you won't see 20. Look for 15 and then pick out the right answer. Cannot get that question wrong. I'll be less than happy. Okay. Again, when we autoclave something, the fact that the autoclave tape turns color, or little indicator papers say it's sterile, it doesn't mean it. Sterilization is biological. We ascertain that by a small tube that we insert in the pack, and subsequently we incubate to see if the endospores in it were killed. That's effectively a way of standardizing it. The same way you have an instrument like a glucometer, and maybe in the hospital every other day you'll have a test strip that, and you're supposed to read 95, and you put it in and it reads 97. It's not standardized. Problem is with it, you've got to make sure any equipment you use has to be standardized. This is the way we do it for a living system. Again, sterilization is a biological, not a chemical definition. So we can't look at the temperature. We can't look at little lines that color in at a certain temperature to make that determination. And again, when we do liquid sterilization, which is also often called cold sterilization, I use the term cold liquid, it's about time. That's why we typically use it only overnight, because there's no way to, during the day, that you could, let's not use something for 6 or 10 or 12 hours, minimum of 3 hours. So, and remember the numbers for pasteurization. Pasteurization, the batch method is approximately 62 to 63 degrees Celsius for 30 minutes. That was Pasteur's original work with wine. Because 30 minutes is a long time, they do what's called HTST, high temperature short time method, which is still pasteurization. They bump it up to 72 degrees for about 15 seconds. So you don't have anywhere near as much time, but it's very, very short exposure to that higher heat, roughly 150 to 160 degrees. Next, and that's why you like heat food to 160 degrees internal temperature. If it's there for a few seconds, you can eat it. You're right. If you're worried about, foodborne disease causing entities. When you see the term for fats, we have to crank it up another 10 degrees for about 20 seconds. That's for things like ice cream or heavy cream that you might have if you purchase the store. It's the same idea, but fats take a little bit longer. When you see ultra high temp method, or what's called ultra pasteurization, it's really more like sterilization. We superheat the liquid in the interior of special containers to about 140 degrees Celsius. That's way hot. I mean, you're up pushing 300 degrees Fahrenheit for about 3 seconds, and you rapidly seal it. So a juice box would be that one. If it says ultra pasteurized, it's a special construction to maintain even dairy items, even perishables, at room temperature. Okay, so you can buy stuff like that. You can go buy soy milk or things. In Europe, almost all that stuff, dairy products are not where we find them in a refrigerated section. They only refrigerate them after. They only require refrigeration after opening. So let's see. Other notes that are important with that, and what we use to ultra pasteurize are vapor phase peroxide, because it evaporates so easily. Vapor phase is that superheated, super concentrated, 140 degrees Celsius. The big problem with alcohol, I should have mentioned this the very first thing. Alcohol is great for the same reason it's bad. It evaporates quickly. A lot of things leave a nice residue, like the biguanides have a residue on the skin that stays there. Alcohols, the great part is they evaporate quickly. You're not going up to somebody with wet hands and they go, ugh, like that. It dries right away. The bad news is it dries right away. Okay, so it's a wonderful item that has become very handy for everyday use because it's easy to use, it's unobtrusive. Like I said, now it's everybody's readily accepted. That's most of the questions for the methods of control, physical or chemical. Viruses, next on the hit parade. Viruses are important because we classify them, and we have to understand the classification is three factors: genome, DNA or RNA, their architecture. Most of them, the default is isometric or icosahedral, same thing, that they're made of identical things called capsomeres, typically an equilateral triangle, and it's like a 20-sided die. You see that in a board game or something like that. That's what an icosahedron is. So when we say icosahedral or isometric, the other oddball shapes are filamentous or helical, which is really incorporates things like rabies and Ebola. And everything else is called pleiform. Pleiform is some shape, not of the other two. And nowadays that's like influenza, parainfluenza, and to some extent I think COVID. As we over time has fallen into that category. So they're not. They're somewhat atypical, might be the word to describe it. So those are the three big factors that are there. Viruses, if it's living, a virus can infect it, whether it's archaea, bacteria, or eukarya. Okay, the only difference is that when it comes to bacteria, archaea is a very specialized virus that doesn't directly affect us, called bacteriophage or phage viruses. The big deal with them is when they attack a bacteria, when they become latent, we have a fancy name for it called lysogen. And if they impart a special property that can affect us, we call it lysogenic conversion. Perfect example is botulism, which is bacteria. Okay, the toxin comes from a viral infection. Diphtheria, bacterial infection, the toxin comes from it. Certain kinds of E. coli, the toxin comes from it. So they can't attack our cells, but they can attract bacteria that can attack our cells. So it's indirect, so you should be aware of that. A lot of the questions are specific as to, what certain viruses are known to do. The one that affects us probably more, typically, the category that I forgot to mention are naked versus enveloped. Naked viruses, those protein spikes viruses attack us by attaching with those protein spikes. In naked viruses, they're right on the capsid. The capsid encloses the genetic materials. It's called the nucleocapsid. And those little spikes are how they attack us. So naked viruses like the common cold or HPV are the ones that we have to deal with because they're very hard to get rid on surfaces. They stay there for a long period of time. Enveloped viruses have a fatty membrane that the spikes attach to. And most antiseptics, and surely all disinfectants, even alcohol, can disrupt that envelope. And if the envelope is disrupted, the spikes are not there. And if the spikes aren't there, it can't hurt you. That's why it's not like an extra layer of protection. It's a relatively easily accessible target for disinfectants and antiseptics. I forgot to mention that. And so why we are so worried about HPV is it's a naked virus that's hard to get rid of on surfaces. That whole toilet seat thing is for real, by the way. And I think it's much more impactful for men versus women just based on how when we use the bathroom, the differences that are there, they're significant. And so that's really one of the big players. And we cover that a lot of times because again, viruses account statistically. You look at all the authors, 15 to 30% of all cancers are directly related to a viral infection, and surely HPV accounts for more than half of those, mostly with cervical cancer, which we're going to revisit again, and even with penile cancers, because there's not a whole lot of the linings. It's not the skin there is not really typical of skin on the genitalia, the external genitalia. So I thought I'd get that to you. So again, that external enclosure made of protein is called the capsid. When it contains genetic material, it's called the nucleocapsid. That capsid, again, the distinction in bacteria, the virus just injects the genetic material. In our cells, it's an interesting process. The virus has to adhere, and then it has to enter. And whether it's phagocytized or it just enters by something called membrane fusion, which we don't have to know. Once it gets in, the whole nucleocapsid is in there. The genetic material in this protein enclosure. What your body does inside that cell, it has enzymes that dissolve that capsid. And effectively, we call that, as a fancy name, it's called uncoating. So you're eventually, as we look into antivirals, first it has to attach or absorb, then it penetrates, then it uncoats. And then what do viruses do? They don't do binary fission, they don't do mitosis, they don't do meiosis. They make a little virus assembly line. They take over the interior cell. They start making more genetic material, either DNA or RNA. They start making capsid proteins. They make protein spikes. They make other proteins if they're part of the package. And so they make them all differently and then they assemble them together. So first it replicates the components, then they assemble, then they release. They release them. If it picks up an envelope on the way out, it kind of pops little, and you remember the illustration, little enveloped viruses pop out. We call that budding or shedding. And like with a cold, different. You make get like 1,000 inside one of your respiratory cells that reach what they call burst size. It bursts, and all of a sudden now you have 1,000 viruses to affect 1,000 more cells. That's why viruses can go. I mean, you could I have a cold coming on, and the next day it's oh my god, I'll never get. And a couple of days later, you're better. It's good. So the big player protein spikes, how they attach, that are there. I hate to do it the old broad brushstroke, but the reality is that in general, DNA viruses, the big concern is HPV and herpes particularly, are because they become latent, many of them. You may never be troubled by them again. You may have a wart once, you might have a cold sore once, or you could have it repetitively. That's latency. It incorporates and it lays there, and we don't know why it comes back out. If you wanted to paint with a broad brush on RNA viruses, they mutate. The RNA replication in our cells is inherently much more genetically unstable. It's just fraught with errors. So, and those are the two big things I think to remember about that. HIV is different. It's a retrovirus. I mean, it starts as RNA, so it can mutate, and it's written as DNA once it gets inside of our cells, and it becomes latent. So it's got the worst of those two problems incorporated. It's one of those viruses like HPV, like herpes, whatever the different herpes viruses are, that once you get them, you got them. Remember, herpes, we discussed 7 different ones that are in that family. HSV1, herpes simplex 1 and 2, oral and genital, even though they can interchange, but typically they're oral, genital are typically more unpleasant, particularly the first or second episodes of them. The third one is the one that all of you pretty much, I'm sure, have been immunized for. That's the chickenpox virus, which is chickenpox shingles, classically referred to as VZV. Varicella, the name for chickenpox. Zoster, the name for the second presentation of shingles. Then you have Epstein-Barr, which is associated with mononucleosis in most of us. CMV, cytomegalo, which is mostly for people who are immunosuppressed and unlikely you're going to have it. HHV6, we'll talk about it when we do skin infections, called roseola, which has statistical association with MS. I don't know that, I don't think we ever established cause and effects suspected as being part of it. And lastly, the one that's an AIDS-defining virus or AIDS-defining illness, Kaposi sarcoma, which is HHV8. In other words, if you are HIV positive, and all of a sudden you get a sore that's biopsied and it's consistent with Kaposi sarcoma, you've got AIDS. And that means you're going to die sooner than later. By definition, that means it means your immune system has collapsed and something's going to get you. It's terrible and tragic, but fortunately still too common. So I thought those are important things to remember. A lot of these, I will have a set of questions that has a category. You'll have 5 of these viral categories, whether it's rhinovirus, whether it's picovirus, picoRNA virus, paramyxo, orthomyxo, retro, where you need to know that some of the diseases we characterized because of that. So some of them more like picoRNA has 2. Genetics, size, shape, and envelope or not. The fact that one of them is respiratory, rhinovirus is the cold, and enteroviruses are fecal to oral is different. They're still in the same category. It doesn't mean they have to spread the same way. So every so often you get some oddballs like that. In that pico or in that enterovirus category, we also have hepatitis A, which unlike the other hepatitises are not sexually transmitted. This one's fecal to oral, and you have polio, which is a real oddball, a neurologic disease that happens to be acquired through contaminated water. And we don't spread it all. By definition, it's not contagious. It's the water that makes it contagious. So you have to contaminated water supply, which is a whole other issue in and of itself. So there's a lot of things that go on with regard to it. So I will have a chart with all the maybe 5 names and maybe 6 or so diseases. Another one that has a lot of players, paramyxo, which has measles and mumps, and RSV, which is a real big player today, respiratory syncytial virus, in the very young and the very old, potentially deadly. So that's respiratory disease. The newborn can be part of that, or put my at the time 96-year-old mother-in-law near death over in North Hills Pacific Hospital. So there's a lot of considerations with regard. The other one would be flavivirus. Flavus means yellowish. So most of these are zoonotic: yellow fever, Zika, dengue, West Nile. Those are all mosquito-borne viruses. Whereas the other one in that category is hepatitis C, which is sexually transmitted. Again, we're not judging it by how it's transmitted so much as, again, size and or shape. DNA versus those are all RNA viruses. Envelopes are not. Those are all that are there. The other key that I have, I'm telling you the key: A, fecal to oral; B, respiratory; C, zoonotic; D, sexually transmitted / blood or body fluids. I'll give you a list of diseases. You tell me how they're spread. Yes, sir. I will. A, fecal to oral. We'd like to say ES and D, or eat shit and dog. Sorry, I had to throw that in. My first wife used that expression. Probably why we're not married. B, respiratory. But we are traveling for change of command together to Jacksonville again. B, respiratory. C, zoonotic, which means it could be a mosquito, it could be like rabies, bitten by a dog or never a cat. Sexually transmitted or / blood or body fluid. Sexually transmitted is a lot of things. It basically means close or intimate contact. So it doesn't always have to be through the blood or body fluids. It can be just like close contact. To a certain extent, that's how genital warts are spread. Yeah. It's frictional more than anything else. Okay, and let's see what else I have to touch on here. So you should know those categories. Coronaviruses are interesting. I don't think we know enough about them. We know now because of all the problems with COVID. It was misunderstood. They're enveloped, so they're not that hard to destroy on surfaces. It's this mutational thing which we're going to get into. Genetic instability in those RNA viruses is a big player, and we'll talk about that. And again, how do viruses hurt you? By and large, it's your immune system. Yes, some viruses like respiratory syncytial will cause cells to fuse. You can't breathe. But by and large, they provoke your immune system just the way cold, flu, COVID systems were all your immune system responding to that virus. And how vigorous or lack thereof response tells you why you might be sick or near death, or you might go, yeah, I got stomach bugs, not a problem. Just feel a little under the weather. That kind of a thing. Let's see. Covered that. And again, another note about HPV. What makes it such a problem? Latency, because it's a DNA virus. It's naked. Okay. It's very simple. Other than that, it's a standard isometric or icosahedral virus. Okay. Yes. That, everybody, in the last few minutes, I will cover the limited stuff on genetics. The biggest single problem with things like bacteria is they are inherently genetically unstable. By definition, our cells are diploid. We have pairs of chromosomes. So if there's a defect or a mutation on the DNA, we have another strand of DNA to cover. So it's not that likely to be expressed. Bacteria have a single strand of DNA. They're inherently haploid. That bacteria is ready to replicate. It's already supercoiled. So if it has that defect, it's going to start to replicate right away. And so you could have a severe mutation demonstrate itself very significantly. That's a big problem. The other thing is bacteria can undergo what's called lateral transfer. You and I send our DNA, our genetics, to our offspring or to our other cells by replicating them identically, but we can't magically change ourselves, not commonly. That's what gene therapy eventually will be about. Bacteria can do that. We covered the three major ways they do it. Transformation, that's when little bits of DNA from dead bacteria are in the environment and another bacteria can absorb them and theoretically change, possibly for the worse. Transduction, where it's basically the same method except a virus kind of is the way that it carries that to the next bacterial cell. And lastly, and most commonly and most problematically, by conjugation. That's the contact transfer. And in order to do that, you have to have a cell that has the F plasmid, the F fertility or sex plasmid, whatever you want to call it, has the information to assemble the F pilus, which is where the attachment is, this hollow protein tube, and the information to allow the transfer. It attaches to another bacteria by that pilus or pilus, and the F plasmid moves from point A to point B. That plasmid has resistance to an antibiotic, it's shared. Okay. And once that cell gets that, it becomes F positive, and then it can contact other F minuses. It will replicate as F positive. So overnight, a whole population could become magically resistant. Staph aureus could become MRSA overnight. And it's happened. I'm not making it seem like being an alarmist and telling you, oh, it could happen. It does happen. So that you have to understand. So if a F plasmid has resistance to an antibiotic, it's also an R plasmid. But R plasmids may or may not be F plasmid. The F plasmid is very specific because it can make the pilus and accomplish the transfer. An R plasmid means it might also have resistance or it might not. So R plasmids are specifically carry resistance. They don't have to be F plasmids that are there. A mutation is an error in DNA. Nearly all the mutations we encounter are what we call spontaneous. If you're making millions of cells, you're going to make some mistakes. Most of those mistakes are not expressed. We call those silent mutations. Occasionally, one will incorporate the wrong amino acid in a strand of polypeptides or proteins. That is a missense mutation. That's effectively what sickle cell disease is, one error. A nonsense mutation means you prematurely encounter a genetic stop code and the protein doesn't get assembled. That's usually pretty bad. That's going to cause some significant problems. Induced mutations mean something has affected the environment, like radiation, like chemicals, and that increases the rate of those things occurring by a factor of 1,000 times. So a bacteria could be, if it mutates at a rate of 1 in a million, now it's going to mutate at the rate of 1 in 1,000. And it's not hard to have 1,000 bacteria mutating a lot that are there. That's an induced mutation. So they are much more problematic. And because they do not have, all they have is mismatch repair, at best a 50-50 possibility, unlike our cells with DNA polymerase III, which typically get rid of most of these. That's why we have such problems with bacterial mutations. Okay, and it sort of translates into other areas as well. Okay, so that's another aspect. Radiation, two types. Ionizing radiation, the worst. X-rays, gamma rays, DNA strands break. Very destructive. The one that we have some wiggle room with is ultraviolet. That's non-ionizing. It causes a subtle change in DNA. DNA is like a zipper, it opens and closes. It causes adjacent thymines to bond together, and it kind of like renders the zipper as being not as functional. We have ways of correcting that in our cells, even bacteria. It doesn't mean it's not important. We use it all the time. Ultraviolet light is just not as devastating or as useful as like gamma rays, how we sterilize blades. In the lab, you're using a blade to dissect, that was sterilized with gamma rays. We have a lot of things get sterilized. So, lastly, again, just about done. All that. Oh, the Ames test. The Ames test has to do with how we check to see if something is something that would affect us because cancer. So the Ames test, we take mutated salmonella, we mix it with some liver enzymes, typically from a rat, and because it needs those enzymes to activate, and we mix it with the agent that the FDA is going to test, whether it's a medicine, a topical agent. If it can reverse or backwards mutate that salmonella to normal, it's such a powerful mutagen, it's going to probably cause cancer in us. That's the Ames test. It takes mutated salmonella and effectively reverses or unmutates or backwards mutates it to normal. And so that also is very important to remember. And lastly, we talked about transposons. In the old days, we used to call them jumping genes. They're on a plasmid. They can jump in and out of DNA. And that's how that corn had that interesting, that we used to call Indian corn in the fall, put there for Halloween, Thanksgiving, etc., etc. See some of you Wednesday and some of you Friday. I'm so happy. I did miss seeing you. Not a lot, but I know. Goodbye.